He's going to talk on thinking outside the box, angled, screwable, individualized, and abutments in implant prosthetic. Yes, please.
Thank you.
He's also specialized in oral surgery and implant dentistry, and chairman in Munich, Germany, International Academy for Digital Dental Medicine, Dental Digital Society, ambassador, slow dentistry in Germany. Yes, please, Dr. Engelschalk.
Thank you. Thank you. What a long day. I know it was hard for you, and I hope I will be speed up a little bit. So thank you for the audience to stay here that long. But first of all, I want to thank you for the invitation, Dr. Park, the committee. It's always an honor to speak here, and especially at the 20th anniversary of my role model and idol for the last years. So it's amazing, and it's also thanks to you, to the audience, being here. Okay, now I want to shift a little bit from the bloody stuff to a little more prosthetic topic. And we want to think a little bit outside the box, because we talked about so much about zero bone loss and how to place, leave the root, but nobody talked about the crowns, the abutments. And I want to do this today. And first we want to get something clear, just some facts, and then we can talk a little bit more in detail. First of all, the factors that are influencing the success, and we saw this today very good, is the fact that bone and soft tissue is often compromised if you do an implant placement. It's never a perfect situation, so we have to deal with compromised bone and soft tissue. The next thing is we have to discuss morphology of abutments. Also very, very important. We saw this Thomas lecture is always an influence. And there is something very important, which is quite difficult for us. So the axis of the implant is ideally coming out at the incisional side. But this is not always possible. We saw this beautiful in the lecture of Howie, that sometimes there is a deviation, and we have to deal with that. The next thing is we have to discuss screwed and cemented. I know it's nearly something like religion. If you ask me, now I'm doing, I would say, 90% screwed, but years ago, I would have to say I do 90% cemented. So there, if you look into the literature, and it's very important, if you look into the literature, take the newest one. Like Thomas told you today, not 1986. We have to look at the new literature because things are changing. Same group, after 3 years, after 5 years, there's nearly no difference. If you look into another publication, then you see cemented, maybe more inflammatory cells. Then we have also a publication, that the cemented group may be a little bit problematic. It's always the same. If you look into the literature, you can create the literature as you like. You have to read the literature in your view. But we can say in this, cemented versus screwed is not a question. We can use both. Using both is the same for digital or analog. So we don't have to discuss if digital or analog is better. Just take the information. We can take both with the same results. First, like Howie, I want to start with not so good cases or not a perfect case. You see, this is a compromised situation. There's no tooth anymore. So we have a bone loss. We have severe periodontitis. It's a problem case. So if you look at our planning, and we planned here with R2Gate, which is, in my opinion, one of the best implant planning software at the moment, you see that we can clearly have an idea of the future crown, of the implant, of the bone, and then we can judge what to do. And you have to respect the angulation. And here I followed the rule, axis of the implant, incisional point, and that you have these axes. And always look at the triangle of bone. Thanks to Scott Gans, we know this triangle of bone now. So this is something very important. Okay, go into the details. Compromised bone, we have to place the implant, we have to augment, we have to do everything what we are able to do to get something out of it, because the tooth was already extracted. There was no root membrane technique anymore. And if you have a closer look on the post-operative situation, then you see clearly the membrane, the augmentation, and everything can heal. But you see directly the planned situation of the implant, the planned access, and now the real access. They differ. Because sometimes we have to change things intraoperatively. And this will become important later because you need information. So these are the access, and we have to deal with them. So that's the result. Screwable or cemented. Well, if we screw something, you can be sure that in this case, the screw hole will be visible. From the aesthetic point of view, not very good. If you cement what we have done in this case, you get another problem. You see the crown is too big. The root part is too big. It's clearly because you need an abutment and you need a crown on the abutment. So from the aesthetic point of view, it was a mistake. It was not perfect. Oh, sorry for that, but it's not that working that good. So we had a mistake. Patient was lucky, was happy there was a tooth, could bite, but it's not the aesthetic outcome we want to achieve. So there should be something different. We need help, and this may be with the help of screwable cemented abutments. So this is a case with a root membrane. Just to show you, when I noticed that I have to lecture after Howie, I said, well, I have to put some root membrane in it because that's very important. It's this famous issue. But this is the best case, or this is the best situation to show you the angulation, the problems of the angulations. And if you have a closer look on your CBDC scan, what you should always do, and this is not an intraoral scan, this is a CBDC scan, then you have to look at the bone. The quality of the bone you can expect if you extract the tooth and if you replace the tooth by an implant. This is very important. And this is something, I would say, the essential message of digital is that you need the same time like an analog workflow, but you have the time at the desk, outside the patient mouth. You can think very easily about problems. You're not under the pressure of the surgery. Now you see, we extracted the tooth virtually, and we can have a look on the root. We can have a look on the crown, and we can have an idea what will be the problem in the angulation. So if we skip this to shorten up the lecture, you see, you can turn it around from every angle because it's a front tooth. It's a very complicated tooth sometimes with the angulation, and we have to deal with that. So that's very important to see that we can really estimate what we have to expect. So this is AutoGate. So you transfer your DICOM data from your X-ray and your IOS or intraoral scan or lab scan, and you can match them. And after matching them, thanks to AutoGate, there is also something like AutoLite. You don't have to match this by yourself. You can just get it like a menu. You just have to eat, not to cook. And then you can see in the middle slide, the angulation can be planned. And this is very important, that before the implant placement, you know all the secrets and all the problems of the patient. So, now we know which angulation we need, and you can check in the software the angulation of the abutment you need. You can switch it, you can change it, because nothing has happened at the moment, it's just virtually. And you get prepared perfectly for your case now, because you can transfer it into the situation, and you can have a look, you can have a chat, and you can rotate it, you can turn it. So this gives you the security of planning. And you see, we need an angulation for this, because otherwise we can't screw it. So in this case, we cut it, the crown, like how he did. It's the same workflow. And if you know me, you will know that I'm a complete digital man. So everything needs to be guided in my case. So that's a little bit too far. So I want to even to guide the drilling of the root, because I'm afraid of the success. No, I'm afraid of creating problems. And who will tell me how far I have to cut the root? So this was the reason why I tried to create something guided in this case. So now you see the results. only provisionals in this case, but it's okay, thanks to the secret of root membrane technique. So these are the guides, the different guides we're using. So you need more guides than one, just because of the angulation. And I thought I would be smart, maybe we can change it. So this is the result, and you see there on the right slide, the angulation of the crown. So, yes. If you go into this case deeper, you see the result, and you see the beginning, thanks to root membrane technique or partial extraction therapy, and thanks to the digital planning. That's very important. So no surprises, please, in your workflow. And if we think about placing implants in the frontal area, you have to go to literature. You have to look at the anatomy. That's very decisive, and that's very important. And we see this is a perfect publication about the different classes of the position of the tooth in the bone. And often we have, or mostly, we have to deal with class 1 and class 4. Okay, that was very quick. You forgot the pictures. It's not a problem. These are the two pictures, class 1, class 4. These are our main customers, you would say, in the office. Okay, what to do? The next thing is there are different angulations. Picture A, you got two angulations, outside in and the vestibular part, the palatal part. And you can create an angle. You got an angulation of the root. And you get an angulation of the alveolar. Now it's up to you where to place the implant, because you want to maintain bone. That's very, very important to think about. And this would be the ideal position of an implant I told you before. Nobody of you would place an implant like this in this case. So you see, placing an implant in the frontal area, expecting perfect aesthetic results is not easy. It's depending on so many factors. And if we look to the literature, you see central incisors, lateral incisors, and canines, they have different kinds of deviations or angulations. So this was a brilliant study. They did it on several teeth. Sorry for that. And you see how they did it. And my idea was now, okay, I'm a digital guy. I want to do everything guided. Why not guide also the drilling of the root, the separation of the root? And this was the reason why we designed two guides. In the middle, there is this new burr we designed. It's not available. Maybe I have a chat with you two guys. If you do the new box of partial extraction therapy burrs, maybe there is also a guided burr inside. And we have the guide for placing the implant, because I wanted to have Howie's golden locks. I want to be sure where to cut the root. So let's go to the case itself. I think I prefer to stay here because it's easier with the... And this is a short video we did. So using two guides, first guide to cut the root and the second guide to place the implant, because we want to be predictable. That's what you have been told today. 2 out of 10 is not predictable. 9 out of 10 is very predictable, but also something like a fairy tale. But 7 out of 10 would be great. So we have to do this. And this is the first guide we're using, just to drill a hole into the root, to separate the root, to be sure where to cut the root, because we planned it already virtually with R2Gate. And then you see it's a trusted workflow, because you're safe in that. And after that, you can remove this part of the root. And by the last lecture, you know how it should be look like. And then you can place the implant with the next guide. And knowing the deviations of crown and root, the hope having just one guide was dying very fast for me. So we always need 2 guides, I think. So just skip this. The angulation is not only existing for the front teeth, we also have these for premolars and molars and canines. So it's very important to know for you the angulation of teeth, because implantation or placing implants today is more than just drilling a hole into the bone. And often I prefer to say that the best peri-implantitis prevention would be a perfect prosthetic. But a perfect prosthetic is also relying on a perfect abutment. The next thing, if you look into the literature, then also look the thickness of the bone. Because if there is bone, it's nice. But if the bone is too thin, it will resorb. So we have to deal with the thickness of the bone. And the next thing is, if we talk about placing implants in the frontal area, are there any resorptions or perforations? So, well, I know this is a lot of information, and going now back to the practical part. But it's very important for you to know the basics, because otherwise it's trying. Yeah. Well, if we look to the portfolio we have for abutments at the moment, angulation is very hard to see. You just have two possible angulations, this and that. The lower is for provisionals, and the upper, we don't use any prefabricated abutments in our office. Every abutment is individualized. So that's important for me because every patient is different. So that leads me to the fact that we need something angulated, which is also at the same time screwable. So you see now there are some different angulations of a screwable abutment where you can cement your crown already on it. But be careful. There's a good study on the fact that the more the angulation, the more the pressure will increase, the stress will increase. So it's not possible to increase your angulation up to 45 degrees without any problems. This is very important to know. This is the reason why we're limiting the angulation, 0, 11, 22. Yeah, that's very important. So you can't solve any of your problems with angulated abutments. So these are the angulated abutments we have at the moment. And you have to deal with the cuff height, means the soft tissue. This is something you can prejudge at the time of diagnosis with a digital AutoGate system. And of course, intraorally. So let's go deeper into the real world, into your daily business. This is a case. Premolar, premolar, molar. So we're coming from a difficult way. We started with a huge resorption, and we had to extract a lot of teeth. And we wanted to end it up here. Sinus floor augmentation. Again, we did everything we can to solve this problem. And if you do such things for a long period of time, this will take nearly 1.5 years. You have to be sure that you don't ruin it with your prosthetics. So planning everything with AutoGate, of course, we know this now. And you have the chance to have a look on every single situation where you want to place an implant. This was directly after the CBDC taken after the healing period of the sinus floor augmentation. And if you have a closer look on your planning system, you can see more than just the crown or the X of the implant. You can see also the quality of the bone where you place your implant. So that means you can estimate how long should I wait to restore everything. And that's her case before treatment. And again, we look at every case before, we select the teeth where we want to place our implants to get an overview how the teeth are looking at the moment with roots and crowns. But there's a problem, or there's a secret behind this. If a root stays like a balcony outside the bone, it's possible for the tooth, but it's not possible for the implant. And with this, you can see that we can try to estimate the root, the shape of the root, and to have an idea how the future position of the implant will be in relationship to the crown. This is very important. We all say, of course, we do prosthetic-driven implantology. Nobody's doing that in real. This is prosthetic-driven implantology because you now think from the crown to the bone to the implant. This is very important to know. And the next thing JC Kim told you yesterday was, by the way, it was brilliant, this discussion on the stage was really flashed by the quality of the speakers and how they present. Everything looked so easy and it was for sure well prepared. But he talked about function. And function is very important for us. If you look to this case, it's the same person. But we have to look at the function, how he will open the bite, how we will rise the bite because of the pressure on the implant and on the prosthetics. Because also a high pressure can ruin everything. So it's a complex situation. Sorry for disturbing your idea. Implant placement is very quick and dirty. It's something you have to think about. The next thing is, I just want to do a short journey with you, because that's not a take-home message, but it's something you may keep in mind where implantology may head to. All these informations, angulation, the situation of the root, the crown, everything, you have to keep in mind if you do the surgery. And we now do something different in our office. We take this information on a virtual Google, and we bring this information into the surgery to have everything available. And I just want to show you how this is working. This is us in the surgery room. You see, I'm just doing something fancy, but I'm moving my pictures I see on the Googles. And thanks to Richard Weig, who is really, he's not supporting, he's the brain behind the whole thing. We are trying to transfer all these data into the surgical room. And I tried to give you a short movie. You see now, the orange and the yellow is the CBDC scan of the upper and the lower jaw. The blue one is the guide. So we now can transfer this information to the mouse, and I can see it with my Google, and we can extract the guide. We can have a look on it, and we always have the information with us during the surgery. Maybe there's not a direct impact at the moment, and for the GP, it's way away. But the future will be like that. And the second thing is that I have always my information with me. The drilling protocol is somewhere in the room. I can put it somewhere. And I can always have a look on it. And I can move it. I don't have to touch anything. So from the hygiene, it's very interesting. But this is also very interesting. You can prepare your case, and you can extract everything. You can have a look on the nerve. You can really be able to have all the information you need. And I think in times of digital, where everybody has Facebook, Instagram, everybody of you is taking information out of the internet. We need more information than we can get. And this is an information you can take into the surgery with you. So, just a short journey, just coming back to the case I showed you. 6 implants, premolar, premolar, molar on both sides. We planned everything, we printed our guide, we got our drilling protocol, which is quite important to know. And after implant placement, everything, you saw already the X-ray. This is the situation, and I made the model for you with the scan body, the intraoral scan bodies. This is the soft tissue plastic situation, and these are the crowns. And now you can see the problems we are facing. These are the angulations of the implants and the position of the crowns. And if we go to the RC abutments, which is the abutment we need, you see now these abutments are changing the angulation for us because we want to screw something on it. Same from the side, and now it's a little bit better to see. You see, we level up the situation of the soft tissue. We level up the situation of the margins. And this is the reason why we need different cuff heights. This is the situation why we need different angulations. Because they have to be on the same level afterwards, because you want to reconstruct this with crowns. And remember my sentence, perfect prosthetic is the best peri-implantitis prevention you can get in your office. That's very important. Or from the other point of view. So then you get a perfect reconstruction. It's up to you. It's not up to the lab technician. Okay, he also has to do his job, but it's up to you. from the beginning, placing your implants at the right position given an angulation. And with these RC abutments we now have available, you can do this, but plan before, not afterwards. There is something very nice you can remember maybe, and to give you a better picture in your mind. When I got divorced, I learned something. Telling something before is explaining. Telling something afterwards is excusing. So it's the same here. Planning before is explaining. Planning afterwards, when everything is done, the implants are placed and healed, is excusing to the lab technician. That's very important to know. And these are the facts we want to keep in mind. There's a really little great problem. The screw. The screw is perfect. You see, it's a different kind of screw, but the position of the screw is decisive. Often, if you use this the first time, you don't position the screw at the right position, and maybe you will get a higher occlusion than you normally expect from your lab technician. Then you already know there is something wrong, because the position of the screw inside the implant is very important. And you can see, if you do a control X-ray, there always have to be a small gap inside the implant. You see there with the yellow arrows. Because then you know the position is right. If you fill up the gap completely with the screw, you know the position of the abutment is not right correctly. The next, or the first good thing with this is, you don't need that high torque. Because this screw is different. There's an upper and a lower part. And because of that, we just deal with 70 Newton centimeter, not more. It's a physical, technical thing. The next advantage is the screw canal. If you can reduce the screw canal, you can make the ceramic bigger. You can hide aesthetic problems. You can also give more strength to the reconstruction. That's very important, because you have a direct access to the screw. Here you see, that's the conventional screw canal on the right side, and it's the new screw canal on the left side, because the screwdriver is also very thin. You don't need more. You will invest into the ceramic. You will invest in the strength of the reconstruction by using this. So, go on. One abutment and one time. I think this is the biggest advantage of the whole story. Maybe you heard the thing, one abutment, one time. That means you have to insert the definitive abutment at the time of implant placement. Very critical thing. Because I can't look into the future. I can't predict the level of soft tissue. I can't predict the level of bone. I can hope. I can estimate from my experience the way I do the implant placement. But soft tissue I can't predict. So the definitive abutment at one time is very difficult. But we know the more you screw on implants during the healing phase, the more problems we're going to create. And if you look into the literature, you can see these results. Doesn't matter who you're looking at. Well, it was very funny to see that he published something also on this topic. And maybe if you don't believe me, believe him. It's very important that we reduce the numbers of screwing. And you see in this study, after 3-year follow-up, how the bone is reacting. So this is not only scientific talk. This has a real impact on your daily business. And still up to now, I reacted by choosing the right scan body, because if you use the scan bodies of the AnyRich system, we have 2 scan bodies available. You have on the left side, you have the standard scan body, which comes originally from the lab side. And you have something called the scan healing abutment. Means you have the scan healing abutment you screw in at the time of surgery. And for scanning, you just click on something. You don't have to remove it. And by using that, you just have to unscrew the screw at the time of inscrewing definitive crown. So just one time, it's perfect. Because we know from the literature, up to 3 times, it's okay. Yeah? So, these are the pictures of scanning. So now we can change, we can shift this a little bit. And there are some publications, they did it with the multi-unit abutments. They screw it in, left it, and then you can adapt something on it. But screwing in the frontal area on multi-unit abutment could be difficult or aesthetically not that good. And here you can see 3 times. Screwing on implants 3 times is recommended, but not more often. So we want to change this. And if you have measured correctly, or if you see an intraorally during the surgery which RC abutment you need, you can screw it in and you can use these caps for healing. Brilliant. Never screw on this implant again. Brilliant. You can leave it. And we can wait for healing. This is the workflow. You can see now you have this one abutment at what time. The next thing is if you have to do an impression or if you have to do a scan. By the way, this funny thing can be used for impression and scan at the same time. If we have a closer look, the thing is where to scan or where to take the level of the implant or where to do the impression. Because we have the impression at abutment level and we have the impression a little bit higher, the situation, so where to calculate. The thing is, even if we have very, very precise production workflows for the implants, we have to deal with some tolerances. And you have to deal with these tolerances for the implants and for the abutments. So in the worst case, if we deal with 20 microns for the implant and 20 microns for the abutment, we have 40 microns. If you do the impression on the implant itself and not on the abutment, maybe the prosthetic won't fit that good. So if you do the impression on the abutment level, you just have to deal in the worst case with 20 microns. So that's very smart here in the system. So at the end, with just 8 minutes left, I want to take all these information into one case. And it's not that a beauty case, it's a regular case, it's a daily business case. Yeah, you see some filling missing, whatever, and we want to restore 2 premolars, 1.5 and 2.5. You see again, like we do this in every case, the planning with the AutoGate system. This is the one. You see the angulation of the abutment, you see the crown, the shape of the future crown, you see that we are willing to screw it, because if we don't do this angulated abutment, there's no chance, we had to cement. And this is the other side, more severe from the angulation. Implant placement, CBDC taken before, CBDC taken afterwards. Everything went white because we did it with a guide. And maybe you ask me now, is there any sense in this picture? Yes, of course. This is a printed model with a scan body on it. And we've been able to put on the implant placement guide, the AutoGate on it. Of course, this will match because it's the axis of the implant, the scan body. It's not angulated. But if you look on the crown, have a closer look, you see that the screw channel is somewhere else because of the angulate abutments. Same for the other side. So this is really important to see that we get the screw now to the occlusal surface, thanks to the angulated abutment. If you have a look on the side situation, you see guide, model, crown. Same for the other side. Both from the occlusal view, and this is really nice to see because the deviation of the scan bodies is really wide. But we are able to screw it from the occlusal side, thanks to these abutments. So this is the intraoral view. You see the gingival healing cap. You can also scan individual emergence profile. It's not a problem. You see the scan body. Move on. I think he's also tired somehow. Lost connections. This is an intraoral situation. And you can cover today perfectly the screw hole. It's not a problem anymore. It's not an aesthetic disadvantage, I would say. Same on the other side. But the only thing is you have to tell the patient that this is a screw-retained crown, because if the patient will go to your neighboring dentist, you know, everything what comes from you is bad at this office. If they want to remove the crown for some reason, tell them it's screwed. It's not cemented, because sometimes they don't see. Yeah, because it's a beautiful outcome just by filling it up with composite. It's not a problem. And these are the shapes of the crowns. Now you see with the screwdriver on the bottom, you see how we can manage these different angulations. And if you go to the CBDC scan, you see the axis of the implants. And of course, you can estimate the axis of the screws. It's made in yellow. Yeah, you can see it. And this is the clinical outcome of the crown in the mouse. And we have to respect the gingiva. We have to deal with the gingiva. We have to support the tissue. And even there, if there would have been a root, we could have done the partial extraction therapy also. And support everything by a perfect abutment. Also the other side, which is a quite compromised situation of the soft tissue. But for this implant, I think it's not a failure. It will stay. So this is the idea for the future, to support your implant, your perfectly placed implant, by the best prosthetic you can get. So after a long day, just a small information about multi-units, because some of you are using multi-units. Multi-units are very helpful, and sometimes we have to do this angulation in dentulous jaws. And therefore it's very brilliant also to have these angulated screwable abutments. Yes, of course we have different angles, we have different cuff heights, and of course we have the same topic with the 15 up to 17 Newton centimeter. And we have the same topic with screwing. Be aware of the position of the screw at the time of placing the crown with the abutment in the implant. If there is everything right, you will have no problems. Control it on the X-ray like I showed you before, looking for the gap in between the implant to have the idea that everything is placed perfectly. And then you can choose also there with different gingiva healing caps, because we want to follow still, in this case, the one abutment at one time concept, which is quite important. And after that, you are free to choose. Do I want to scan? Do I want to do an impression? Because we know that scanning in a dentulous jaw is somehow a little bit difficult. Everything is available because you're screwing on the RC abutments, on the angulated abutments. This is quite important. And you have different types of temporary cylinders. You have also if you know, the surgeon abutments, means these are abutments you can combine with zirconia. So everything is available, even for these kinds of indications, which is quite important in my way. So the last 2 minutes I want to use to summarize a little bit of the long day. Even for me, it's hard to remember everything what I heard today. Please take home, angulation counts. That means angulation is a common problem for us for every tooth in the mouth. It's not only for the front tooth. The next thing is that we can't bend the angulation up to, 90 degree. It's not possible. There are reasons for angulations. The next thing is data counts. That means the data you are collecting, CBDC scan, intraoral scan, whatever, face scan, they are important. But they're not only important to have a first look on it, they're important to do something, to plan everything in advance, as much you can. The more you can plan in advance, the less will happen or will go wrong in the surgery. The one abutment at one time counts, because it's important. We don't want to disturb the whole situation of soft tissue and bone too much. Let it heal. And we have the solutions to do it with one abutment at one time. And your preparation means your skills, your knowledge counts at the end, which is quite important. So if you're willing to change concepts to new concepts, and we heard a lot of concepts, and I will take your bone concept with me at home because it was very thrilling for me to see cutting the bone even in thin situations. That means your preparation is so important. We can give you tools, but you have to use them. And by having this beautiful picture of this unbelievable beautiful library and so, I want to thank you for your attention, for your time, for motivation staying with me the whole day or the whole lecture. Thank you very much.
Thank you, Marcus. I think your lecture is perfectly fitting the theme of our symposium, inspiring the future of dentistry. I think maybe colleagues want to ask some questions about this topic. Any questions, please?
Well, it's not a problem. I'm used that digital has no questions always. That's normal.
Gulukma, you want to ask him? Yes.
Thank you very much, Dr. Marcus, for the very interesting, inspiring lectures on the prosthodontic part. My question is with regards to the emergence profile. When we do, especially in the anterior zone, where we have to create the emergence profile. Now, with regards to the RC-based, how, because it's one abutment one time, so how do we create the emergence profile? Copy the emergence profile from the temporary restorations?
Well, you got my weak point. The thing is, I shortened up the movie with the surgery. We used a prefabricated screwable provisional. And we unscrewed it after the healing period. You saw the case. Well, in the frontal area, it's difficult for me. I don't know a solution, to give you a solution. Because we can manage a lot of things in the canine, or maybe in the premolar and molar. But for aesthetic reasons, we always need perfect provisionals. We have to support the soft tissue. And Thomas showed you today all the lectures talking about immediate placement. They showed you individual abutments you can use for a molar, but not for a front tooth. So in the front, we're using like how we did, or we did it prefabricated in the lab. We use screwable provisionals. We have to unscrew it. It's very difficult for me to follow the one abutment and one time concept in the front area. That's my weak point. Great, good. Touché.
Just, I'll give you a philosophical question.
Yes.
What do you think the future of digital is, and what is the most exciting thing that you think is coming that's going to really revolutionize and change the way we do dentistry? No pressure.
Well, no, I have wishes. My biggest wish would be something like a fork. You bite on, just push the button, and the scan is done. I don't know if this will happen. The next thing may be something like a MRI, you say, magnetic resonance frequency, not frequency, it's not a CBDC scan, it's without radiation. Maybe we have this. MRI, thanks. The Google is not the future anymore. The Google is, for me, it's daily business, that I have everything available. Because normally you would ask the people, artificial intelligence or artificial reality, virtual reality will be the future. No, that's a present. That's no future. But tools like the fork just make it easier, the life. That would be the future. Not the robot. Maybe the robot will come when I get retired, but not before.
You showed some fascinating cases where you were able to segment your CBCTs beautifully. Obviously, that depends on scatter and the ability to... What CBCT were you using, and what software? Is that a software specific for your CBCT?
Okay, it's always the same question when I show this picture. Honestly, it's no surprise, and it's not prepared. I'm using the Artist Studio, proudly for 2 years now. And with the Artist Studio, we really get perfect picture, even if there are some artifacts, some metal crowns. And this software was DentoCut, DiagnoCut. This is a perfect software. It's an artificial intelligence. You transfer the DICOM data, I would say in 2 minutes of a CBDC scan into STL files. And then you can ask the artificial intelligence about the diagnosis of a periapical, of a panoramic, or of a CBDC scan. And you will get written everything very detailed. And I'm using it to transfer everything in STL because STL is my language I have to use. DICOM is okay, but for all these digital tools we're using, we need STL. DiagnoCut, that's the name.
Thank you, Marcus. Are there any questions? So, if not, I think that's a very deep topic for them.
Thank you so much for your lectures, doctors. 네, 자, 이번 세션은 이렇게